Hello, my name is Dr. Andras Székely, and this is the second part of my talk on gastrointestinal and abdominal radiology. Last time we talked about the bowels and their various diseases, but I think I missed one thing, which is free abdominal air. Free abdominal air is easily appreciated on a chest x-ray or on an abdominal x-ray. So if you see a crescent-shaped lucency below the dome of the diaphragm, either on the right or on the left, then that is diagnostic for free air and the need for surgery is imminent. Or the same thing is that if you see a pocket of air outside the lumen of the bowel, then that is free air. I think that many of you are familiar with this image. So we usually divide the abdominal cavity or the abdomen up into 4 quadrants, and according to the different quadrants, there can be various sources of pain. I would just like to walk you through the right upper quadrant pain and the diagnostic algorithm of it. So let's suppose a patient comes into the ER with right upper quadrant pain that is lasting for longer than 30 minutes, building steadily, and it's interrupting the patient's activities. And so these questions are usually asked at the ER department. So is it relieved by bowel movements? Is it position related? Or does any acid suppression help or not? So a lot of diseases can be ruled out by just 3 simple questions. And then it's either endoscopy or ultrasonography that comes next. I guess it depends on the local doctors. In my department, in my hospital, we would perform ultrasound first and do the amylase, lipase, so some sort of a blood test. And so at this level, we could rule out gallstones, kidney stones, pancreatitis, etc. And then the patient would be transferred to the internal medicine department for endoscopy, where they could rule out peptic ulcer, reflux disease, or gastric cancer. So about, I would say 80 or 90% of diseases are caught at this level. If all of these diagnostic tests do not reveal the true nature of the cause of the pain, then we could do further imaging, which is CT or MRCP or endoscopic ultrasonography, which are of course more costly and mean some sort of discomfort or radiation for the patient. So we would leave these for later. And then let's suppose we find the reason. So this would be the yes. Then we would go back to this rectangle, this purple rectangle with number 11 next to it. If these imaging techniques do not reveal the abnormality, then we would perform a specific DISIDA test to check for gallbladder ejection fracture. And if it's less than 40%, then we can diagnose a functional gallbladder disorder. If that is not the diagnosis, then we would consider sphincter of Oddi dysfunction. So I think that this is a very nice algorithm that highlights how doctors should think and when to order the different radiological modalities. If you're interested in reading more of these diagnostic algorithms, then I would point you to this source, which appeared in the American Journal of Gastroenterology. And this is an image from the ACR's appropriateness criteria. So if our patient has right upper quadrant pain and we suspect a biliary disease, then ultrasonography is the most appropriate, because with it we can rule out cholecystitis, pancreatitis, gallstones, etc. So a lot of the common things, the common diseases can be ruled out with a cheap and fast imaging modality And then if we are not sure, then we can move on with the diagnostic algorithm that I presented to you on the previous slide. Now let's turn our attention to the liver. And diseases of the liver can be either diffuse or focal. You can read through this slide on your own, but I just wanted to highlight the most common ones that we encounter. So fatty liver, cirrhosis, hemangiomas, and metastases are probably the 4 more common diseases that we encounter as radiologists. And I will show you what we see on the different imaging techniques. So there are indications for CT. It's usually ultrasonography that comes first, and then we move on with the more heavy artillery, such as CT and MR. So CT is good to further differentiate what we have seen at ultrasonography. It's good to image the patient before he or she moves on to surgery. It's great to image the veins, the arteries and the veins. It's great for abdominal trauma and to assess for inflammation and abscesses. This is a very busy slide, but I think that the sentence that I made bold sums it up best, is that MR sits on top of the modality list. So if neither ultrasound nor CT can answer the question, then MR comes last, and MR usually is able to answer the question. Or if it still can't, then we can always do a biopsy or surgery. So steatosis or fatty liver can be either diffuse, as it is seen on the left image, or focal. And at CT, it's quite easy to put a region of interest on the image and measure the density of the area. So as you probably know by now, fat is black on the CT image, and it usually has a negative Hounsfield unit value. And so if the liver becomes darker on consecutive images and the density lowers, then that's diagnostic for fat. We usually consider 40 Hounsfield unit or below to be fatty liver, because the liver normally has a density of around 50 to 60 Hounsfield units. And the same thing is that if you see a circular lesion, but if you can measure fat in it, then that's probably just focal fatty deposition. And at ultrasound, fat is hyperechoic. So if it's a diffusely fatty liver, then that would show up as a diffusely wider liver at ultrasound. And if we see a circular lesion, then that can be focal deposition of fat in the liver. Cirrhosis is unfortunately a common problem, not only in Hungary but worldwide. And so at imaging, we usually see that the left lobe of the liver becomes larger, as you can see it over here on this contrast enhanced image, and the 6th and the 7th segments, so the right lobe of the liver, will atrophy. The goal of radiology is to image fibrosis and the different types of nodules, and to differentiate early cancer from metastases and the rest of these nodules. So take a look at these two images. The upper image is a non-enhanced series. There's no intravenous contrast in the aorta. There is contrast in the bowels, but that doesn't mean that it's a contrast enhanced image. And the lower image is a contrast enhanced image in the venous phase, and the arrows are pointing to an area, a dark area on both series, which doesn't enhance as much as the living parenchyma does. So that is fibrosis, because fibrous tissues, as I probably have mentioned before, but I will mention it a couple times today, So fibrotic tissue enhances much later than normal liver parenchyma. And so based on this imaging, you can say that the surface of the liver is a little bit uneven. The left lobe is enlarged, the right lobe is atrophied, and there is an area which is fibrotic. And fibrosis in cirrhosis can affect segments or even whole lobes. Sometimes we see iron-containing nodules in the cirrhotic liver, and they will show up quite nicely on the non-enhanced series because iron-containing compounds will show up as white areas, and usually these fatty livers are quite dark, so there's a great contrast in between them. So these yellow arrows are pointing to iron-containing nodules. And then the middle top image is showing to you that there are nodules in this liver, but they are not enhancing any differently than the rest of the liver parenchyma. So these are regenerative nodules. And this is a surgical photo of the same liver. And the bottom right image shows you that these nodules are now enhancing a little bit differently than the rest of the liver parenchyma, but one nodule in particular is quite different. It's quite inhomogeneous. And please observe that the patient has a lot of free abdominal fluid, which is also a sign of cirrhosis. So let's observe this one nodule, which in the arterial phase is quite inhomogeneous, and in the later phase, in the venous phase or the later phase, is hypodense relative to the liver. And sometime later, this nodule grew even bigger and became even more homogeneous. So this is now very suspicious for HCC. Regenerative nodules are part of the cirrhotic liver. They contain liver cells and fibrous tissue. It's important to note that the reticuloendothelial system cells are present. They are 3 to 10 millimeters in size, and they take in both arterial and portal blood supply. And at this point, I think it would be very important to recall anatomy, and that normal liver parenchyma takes 2/3 of its blood supply from the portal system and 1/3 from the arterial system. So at ultrasound, these regenerative nodules are the same color as normal parenchyma, and at CT they are also the same as normal parenchyma. Of course, if they contain iron, they can stand out, as I have shown to you before, and at MR, the presence of iron also distorts the signal, so the contrast difference is pronounced between normal and abnormal. Here is the continuum from regenerative nodule to HCC. So these nodules will eventually become dysplastic and go from low grade to a high grade dysplastic nodule, and then become small or larger HCCs. And at the same time, their blood supply changes because they will gradually take in more blood from the arterial system, and their portal supply will gradually diminish, and this will be reflected by the CT appearance. So dysplastic nodules are precancerous. By definition, they are larger than regenerative nodules, and they are usually T2 bright. And since they are densely packed, because they are precancerous, then diffusion will be restricted, so they will show an increased signal on the DWI images. So if ultrasound detects a nodule in the cirrhotic liver, then automatically we will take the patient and image him or her with CT or MR, whichever is available, and we will check for hypervascularity of that nodule. If it's positive, then we will check the portal or the venous or the late phases of the series. And again, if there is washout, then that's diagnostic for an HCC. If there is no washout, but the nodule is hypervascular, then clinical suspicion is still going to be high for malignancy. So we will have to do further imaging. We can either do the super paramagnetic iron oxide MRI, or we can do specific ultrasound examination with contrast, and we can try to prove that that nodule is HCC. If we cannot, then we will follow up the patient closely. And again, we can start with ultrasound. Different institutions have contrast enhanced ultrasound, and if they see arterial hypervascularity, then on the same modality they will also look for a washout, because these lesions behave the same way at CT, MR, and contrast enhanced ultrasound. So if they are hypervascular on the arterial phase and they show a washout, then that's diagnostic for HCC. If they are hypervascular but do not show the washout, then that's ambiguous, and we need further proof for HCC. Here is how HCC will look on CT. So it's going to be bright on the arterial phase. Please note that the aorta contains a lot of contrast material. And then on the portal phase, it's going to become hypodense. So that's the positive washout phenomena. And on the late phase, it's still going to remain hypodense. So that's still the washout phenomenon. At MR, on the arterial phase, it's still going to behave the same way. So it's going to take up a lot of the contrast material. And on the DWI, it's going to be high signal, meaning that it's a densely packed area. It's cancerous. So that's diagnostic again for some sort of a cancer. And if you observe all of the series, then you can make the diagnosis of HCC. The ADC and the DWI images should be read in together, and we only consider restriction of diffusion if that same area shows high signal on the DWI and low signal on the ADC. But I don't think you'll need to know that. I am just telling you this. I'm just telling this for those of you who might become radiologists. So when we perform CT or MR imaging with contrast, then we usually give the patients oral contrast material. When we perform CT, that's usually water. We give them like 2 liters of water and tell them to drink it before they can go into the CT imaging room. At the CT imaging room, they are given intravenous contrast. If it's CT, then that's iodine based. If it's MR, then that's going to be gadolinium. And then depending on the clinical question, we can either choose to do a non-enhanced with series without contrast, a single phase, a double phase, but I think that the most common is to perform a 4-phase CT, meaning that we'll do a non-enhanced, an arterial phase, a portal phase, and a late phase or interstitial phase. And just to remind you that HCC is best diagnosed on the lipidol CT. I have talked about this 2 weeks ago. So if you're not sure what are on these images, then please go back to that talk. And this schematic drawing shows how the different lesions would behave at CT. So let's take a cyst, which is indicated by this circular area and number 1. So cysts do not enhance at all. So this area will remain hypodense, is what this image is trying to suggest to you. A hemangioma, on the other hand, will be it's usually isodense or hypodense on the non-enhanced series, but it will show a very specific enhancement pattern where the lesion will fill in from periphery towards the center, and on the late phase or interstitial phase it will become the same color as the liver. And then the rest of these lesions we will talk about on the rest of the talk. So when we see a focal liver lesion, we want to know where is it, how many are there, how big is it, in which segment is it is located at. We want to know about the structure, its environment and connection to the vessels. We want to know if there is parenchymal disease like cirrhosis and whether there are any dilated bile ducts or not. So here are some cysts. Let's begin with the ultrasound image on the right. So you see this nice and sharply demarcated round anechoic lesion that shows posterior acoustic enhancement. Please remember this because there are test questions regarding this image. And the same, or not the same, but a similar lesion at CT is again it has nice and sharp borders. It's hypodense, and if you measure the density within this lesion, you will get a number between 0 and 10 because these are water density lesions. Hemangiomas are quite interesting and we frequently encounter them at ultrasound. They are usually hyperechoic and have sharp margins. They're homogeneous, and histologically they contain blood-filled vascular spaces and the blood flow within them is quite slow. If they're bigger, then they can look a little bit more menacing. They can be cystic, calcified, scarred, etc. But at ultrasound, they show a very specific and beautiful sign, which is the chameleon sign. That means that if you image the same lesion on, let's say, when the patient is supine, then you will see a sharply demarcated hyperechoic lesion. But if you ask the patient to turn on his left, for example, then the blood flow will change in the hemangioma, and so the color, the appearance will change at ultrasound. So the same lesion will now become hypoechoic and will have a hyperechoic it will have a hyperechoic rim. You do not have to remember how the color changes. You just have to remember that hemangiomas have this very elegant sign, which is the chameleon sign. So when the patient assumes a different position, the hemangioma will change its echogenicity. Hemangiomas, as I have told you before, show a very specific enhancement pattern, which is centripetal. So this is the non-enhanced on the top left image. Top middle image shows that the periphery is enhancing, and top right image shows that the lesion on the venous phase is now completely filled in with contrast material, and these three images are diagnostic for a hemangioma. Hemangiomas are sometimes small, or they can be just as big as half of this liver. So even though this is a menacing looking lesion, it still shows this nice centripetal filling, and so this is diagnostic for a hemangioma. Hemangiomas show the same behavior at MR. They are usually T2 bright, which is the top left image, and then we will do the T2 weighted image without fat saturation. It is the same color, so this lesion doesn't contain any fat. That's what these images A and B are telling us. And then before contrast, it's nice and sharp, and then when we add the contrast on image D, you can see the typical enhancement pattern as we have seen at CT. FNH are more common in females and they are usually solitary. They are benign and they do not require any treatment, but we need to have a diagnosis. For one, we need to reassure the patient that they are not going to die, and two, we need to know the diagnosis so that the patient will not be offered any more imaging or biopsies, for example. All liver cells are present in an FNH, but they are arranged differently than in normal liver parenchyma. They can cause abdominal pain, and they have blood supply from the hepatic artery, and their venous drainage goes into the hepatic veins. However, they do not have a portal venous supply. They look hypoechoic at ultrasound and they are hypervascular. If you have a good enough machine, then you can diagnose the so-called centrifugal circulation. So it's exactly the opposite of what we saw with hemangiomas, because here the blood goes from center to periphery, and if you were to give contrast, you could probably see that, but it's very, very difficult to see that. You need a very, very good machine to be able to diagnose that. So we usually just see a hypoechoic lesion, and we will suggest that this might be, amongst other things, an FNH, and then the patient will go on to CT, and then at CT we will see a subcapsular lobulated lesion, which is either the same color as the liver or a little bit more dark, so hypodense. And if you give the patient contrast, then the lesion will enhance homogeneously. However, bigger lesions will contain a scar, which is fibrous tissue, and I hope that many of you have guessed that the fibrous component will enhance, but it will enhance later. And so depending on the time that passes between the arterial and the venous series, the appearance of the fibrous scar will be different. If you wait 30 minutes, then the scar can eventually disappear from your eyes because it will gradually take in the contrast material. And again, that's diagnostic for an FNH. You don't need a biopsy, and the patient can be reassured that they're not going to die. FNH at MR. So at T2, hemangiomas were bright. FNHs are the same color as surrounding liver parenchyma. They enhance vividly and homogeneously. They can contain a scar which doesn't enhance at this moment. However, later on, the fibrous component will also enhance, and the whole lesion will become the same color as the liver. And again, that's diagnostic. Oh, and since all liver cells are contained in an FNH, then if you're not sure, based on gadolinium studies, then you can give the patient these more expensive but better contrast media, which are hepatocyte selective. So if this lesion takes up the Tesla scan, then that's diagnostic that there are normal cells within this lesion. And if you give it paramagnetic iron oxide, then that will prove to you that RES is present in this lesion, and that might get you closer to the diagnosis if you were not sure about the diagnosis based on the gadolinium study. Adenomas are even more menacing on ultrasound because they are usually large, around 5 centimeters. They are also subcapsular in location, and even though they are benign, they carry a risk of life-threatening hemorrhage and potential for malignant degeneration. They're more common in women because they might take anticoncipients. They can have a capsule. They contain fat cells, and fat, as you recall, is bright on ultrasound. So if you see brighter foci within this lesion, then that can help you a little bit, but we seldom make a sound diagnosis on ultrasound. Ultrasound is more like a screening tool. So you perform the ultrasound, you see a lesion, and then you tell the patient not to worry because ultrasound is not histology, but before histology we can perform further imaging with CT and MR, and that can get us closer to the final diagnosis. But ultrasound seldom gets us close to the final diagnosis. Kupffer cells are present, but they're not functional, and that's very important. They can be multiple, and yes, fat and hemorrhage might make it hyperechoic on ultrasound. Here is how an adenoma would look on a CT study. So if you give the patient contrast, then you will see faint circular areas of enhancement, which is inhomogeneous. However, since these are benign lesions, then they will become the same color on the venous phase as the liver parenchyma. So there's no washout here. These are benign lesions. However, if there is hemorrhage within the lesion, then on the non-enhanced series, this is the bottom right image, the arrow is pointing to a hyperdense area, which is blood within the lesion. That's not good. And if there is fat, then you can also make that visible by putting a region of interest over the area and measuring the density of the lesion. Adenomas on MR is a little bit more powerful in the sense that it's much more it allows a much more objective way of assessing for fat. For example, there is a specific pair of series, which is the in phase and out of phase series, which if you read concurrently, then you can diagnose fat very objectively. So there is a lesion in the right lobe of the liver. On the in phase, it's not really showing up. However, on the out of phase image, it becomes, or some of it will become low signal, and that's diagnostic for fat. At the T2, it's ISO intense, so it is the same color as the liver. However, here I wrote it's high signal, but you need to understand that textbook radiology and real life radiology differs a little bit. So what is written in the textbooks is not how lesions will appear usually on the different imaging modalities. So that's why there's a little bit of discrepancy between what I said and what is written on this slide. However, adenomas will behave how we expect them if we give the patient gadolinium. There will be bright and homogeneous enhancement. And if you give the patient Tesla scan, then these lesions will enhance the manganese because there are normal cells within this lesion. However, they will not enhance the iron oxide because even though RES is present in these lesions, they are not functioning. The one problem with an adenoma is that it's sometimes very difficult to differentiate it from an HCC. The patient's history and presence of cirrhosis and increased alpha-fetoprotein levels can help you, but if nothing does, then you can just perform a biopsy. And now we have arrived back to Well, not back to HCC, because before I just talked about cirrhosis, but cirrhotic patients usually develop HCC. That's why it's such a common tumor type. As written here, cirrhosis is a risk factor. It can be either solitary, multifocal, or diffuse, and it tends to have a fibrous capsule. It can contain hemorrhage and necrosis if it's a fast-growing lesion. It is hypervascularized and shows the washout phenomenon. It is very, very important, and it loves metastasizing into the liver and lung, and some of the lesions will contain fat within them and copper even, and all of this knowledge can be used for diagnosis. However, on ultrasound, HCC has many faces. So it can be hypoechoic, hyperechoic, or inhomogeneous, hypoechoic, hyperechoic. And if you give the patient contrast material, then you can see that on the arterial phase it enhances vividly. However, on the late phase it'll wash out the contrast material. Sorry that the captions are missing, but I hope that I have been able to correctly or understandably say what would be written over here. If not, then please check my source. At CT, they can be small or large. This is a menacing looking large lesion in the right lobe, even crossing over to the left lobe of the liver. It has faint margins and it's quite inhomogeneous on the non-enhanced. On the arterial phase, it becomes even more inhomogeneous. And if you wait a little bit, then the fibrous capsule will gradually enhance on the venous or on the late phase. And not a lot of lesions have a fibrous capsule around them. So that also helps you with your diagnosis. If there are bright areas, then that could signal to you the presence of copper, as I have said before. Or if you can measure the lesion and you can prove that there is fat in it, then that all add further proof to your diagnosis of HCC. HCC on MR. So again, on the arterial phase, it will show heterogeneous enhancement and will show the washout phenomenon. In phase, out of phase images in the middle, this is diagnostic for the presence of fat. And the DWI shows you that this is the densely packed lesion, so it's very likely to be malignant. And again, you can use the specific contrast media to add further proof. And then we are now with metastases. They are very common. They are more common than primary cancers. They can be hypovascular, and calcified, depending on the origin. On ultrasound, they are usually hypoechoic with faint margins, and most of the time we see this target appearance where the lesion has a dark edge and a wider center. And when you see something like this on ultrasound, it's quite gross, because these livers are usually quite large. You can actually palpate them, and these nodules make it very wavy. The contour is quite wavy, and it's a little bit gross to touch. However, on CT, these lesions will show a very similar appearance. These target lesions will not enhance in their center. Their periphery will enhance, If they are fast growing, then they can go under necrosis. That's why you see air within this lesion. They have very faint and blurred margins, and most of the time they are multiple. Echinococcus cysts usually come from some form of worm, and we see cysts which are well circumscribed, solitary or multiplex. They have definable walls and can contain calcifications. The wall and the septa, so these are the septa within the cyst, and this would be the wall of the cyst. They will enhance, and within the cyst there will be daughter cyst or some sort of debris. And of course there are therapeutical regimens that you can use to treat them. Abscesses are fortunately not that common in the liver. An ultrasound is suggestive, but it's not diagnostic, and neither is an X-ray. But again, for those of you who might become radiologists, I wrote this on my slide. CT is very suggestive and typical. So the center of the lesion will be liquefied. It will have a very low density that you can measure, and you will get a number that is close to water density. And then you will get a dense capsule which surrounds the lesion, and that part will enhance the contrast material. And then there's an outer hypodense, so dark circle, which is made up by the edemic compressed liver parenchyma, and this will enhance much later, if at all. Abscesses can be large, or they can be small and multiple, and I hope that all of you know by now that lesions which are close to water will become high signal or bright on the T2. And again, the contrast enhancement is very similar to that seen at CT. Cholelithiasis is very common. We encounter them at ultrasound quite frequently, and they come in different shapes and sizes. So they can be very small, or they can be even as big as 3 or 4 centimeters. What is very diagnostic is not only this hyperechoic lesion, but the posterior shadowing behind it, because the ultrasound waves cannot get behind calcified lesions or bones, and so that's why you see this posterior shadowing, which is completely different than the posterior acoustic enhancement that I talked about when I talked about cysts. So please do not mix the two. Caroli disease is an inherited disease in which the intrahepatic ducts are dilated. So normally there is a vein and there are the ducts surrounding it. In this disease, these ducts are dilated and they can become quite large. And so at CT, you see the central dot sign in which the normal caliber portal vein, which is indicated by the blue arrow, is seen among the dilated intrahepatic ducts, and there is the classification of Caroli disease. So what you see on CT is probably the type 5 over here. MRCP is an MR technique which is a heavily T2 weighted series. So if it's T2, then that means that those structures that contain a lot of water will show up bright and white. And if you go back to my talk on contrast media, I mentioned that we ask patients who come for an MRCP to bring some pineapple juice with them. If you do not remember why, then please go back to that talk. So bile and the pancreatic juice and even the juice in the duodenum contains a lot of water. So if you perform an MRCP study, then all of these structures will show up nice and bright. And if there is a gallstone, for example, then that will show up as a defect, a dark area within the common bile duct, for example. Or if there is dilatation in the pancreatic duct, then that will show up as a high signal area that's connected to the main duct. So that's why we would perform an MRCP study. There is a more specific type of MRCP study in which we give the patient secretin, and it is a very sensitive diagnostic tool to detect chronic pancreatitis. So for example, here is this top image on which just a normal MRCP was performed on image A, and you can see the gallbladder, the common bile duct, and the pancreatic duct. And then the patient received secretin, and then the middle image shows you that along the pancreatic duct there are small dilatations, and that is suggestive of chronic pancreatitis. This is not normal. However, 15 minutes later, you can see that the duodenum is now filled with hyperintense juice, which is interpreted as preserved pancreatic exocrine reserve. So even though this patient has mild chronic pancreatitis, the pancreas is still functioning properly because the feedback system, the normal hormonal feedback system, is still working. And then here is the lower image. On image A, there is a dilatation in the area of the uncinate process of the pancreas. So this would be the pancreas head. Here is the Wirsung, and then this is this dilated area, which is suggested of a cystic tumor. But we need to prove that this cystic area can be connected with the main duct. So we give the patient secretin, we wait a couple minutes, and this blue arrow is showing to you that there's a faint white tract between the main pancreatic duct and this cystic area. And so this is suggestive of an intraductal papillary mucinous tumor. Gallbladder carcinoma is quite rare, but when we diagnose it, it's usually quite advanced, and it's also easy to overlook, especially on ultrasound, because most of the times people who develop gallbladder carcinoma have a gallstone, and just the fact that there's a gallstone and the posterior shadowing, that can hinder our ability to diagnose carcinoma. So these are usually large masses that form and replace the gallbladder, or you can see uneven wall thickening that gradually eats its way into the liver. You can see that the original wall of the gallbladder contains this eggshell type of calcification. It's quite a heavy type of calcification, and it's predisposing factor for gallbladder carcinoma. Or sometimes we can catch it at a very early stage when it's only visible as a polypoid lesion that's protruding into the lumen of the gallbladder. Cholangiocarcinoma is also a nasty type of cancer. It can be a mass-forming type, or a periductal, or an intraductal growing type. And it's an adenocarcinoma because it rises from the epithelium of the bile ducts. And so if it's a mass forming, then you will usually see a large lesion that is hypodense, and it has blurred edges, and in the vicinity of the lesion there are usually these dilated bile ducts. And you can see that this lesion in particular, on the late phase, shows you that it's encasing, so it's growing around this portal vein. So it's quite an advanced cancer. If it's a periductal infiltrating type, and if it's in the hilum of the liver, these are usually small, but they're quite aggressive, and they cause significant bile duct enlargement or dilatation. This is a Klatskin type of tumor. So all of these are cholangiocarcinomas. And now we have arrived at the pancreas, acute pancreatitis in particular. So according to the diagnostic algorithm, the diagnosis of pancreatitis is clinical. They will check the blood test, they will ask the patient a couple questions, and based on those, the clinical diagnosis is usually formed. However, at most institutions, an ultrasound is performed, in which we will usually see that the pancreas becomes thicker and thicker. So it enlarges. It will become darker or hypoechoic due to the fact that it becomes edemic. Its duct can dilate, and if we are examining the abdominal cavity anyways, then we can check the gallbladder and we can assess for gallstones, which are very common causes for pancreatitis. If the laboratory findings or the ultrasound findings are equivocal, then we can perform CT, but again, that's radiation, that's a costly type of examination. So our first diagnostic or imaging modality would be ultrasound as per ACR guidelines, and if we are not sure, then we can perform CT later on. Now, if we perform CT, then as radiologists, we use the Balthazar CT Severity Index. So we check the pancreas. Is it normal? Is it enlarged? Is there peripancreatic inflammation? And if you take a look at the top right image, you can see that along the body and tail of the pancreas, there is increased fluffy density. This would be the inflammation. Around the head, there's this low density area, which is peripancreatic fluid. We check if there is one or two or even more peripancreatic fluid collections, and then we check for necrosis, because if there is necrosis, then the outcome of the patient is or decreases quite rapidly. And so take a look at the bottom right image, which was taken 3 days after admission. Here you can see that on this contrast enhanced image, much of the pancreas doesn't take up the contrast material, so that's suggesting to us that there is necrosis, and the necrosis is quite severe because it affects the body and the tail of the pancreas. So in this case, the necrosis is probably larger than 50%, so we would give 6 points based on just this one finding. Clinically, there is the Ranson and the Apache 2 criteria, which you can find on the internet, and so these are not radiological criteria systems, these are clinical, and they can predict the prognosis of the patient after admission based on their age, their pre-existing conditions, their lab findings, and even their imaging findings. So these systems, these score systems, make medicine objective and predictable, and I think this is the beauty of modern medicine. So please check these out. Even if you do not learn them later on, at least you will remember that you have heard about these, and if necessary, then you can learn these later on. I talked about fluid collections and how important they are with the Balthazar system. So if the pancreatitis is not the severe type, then in the early stage we might see 1 or 2 low density fluid collections, and these fluid collections do not have a wall because these fluid collections are due to the fact that activated pancreatic enzymes leaked out into the surrounding tissues, and so they are not contained by a wall. You can see on the top left image, indicated by this yellow arrow, that there is this low density fluid collection. Again, we can measure the density and we will get a number between 0 and 10. And a couple days later, when the pancreatitis disappeared, then this fluid also regressed spontaneously. However, if a fluid collection doesn't go away on its own, then it can develop a wall, and then a so-called pseudocyst might form, which can cause pain for the patient. And in such cases, we can drain these pseudocysts with a catheter at the interventional radiology department. Here you can see on the top right image a quite large pseudocyst along the corpus and tail of the pancreas, and bottom right image shows you a pigtail catheter which drained out this cyst. Let's talk about necrosis. This left image I have shown you previously. So if any part of the pancreas doesn't enhance the contrast media, then that's suggestive of necrosis, and that's not a good sign. If the necrosis is small or not detected and not cleared out, then they can also assume a wall around them, and then we will see a lesion which is quite similar to the one that we have saw previously, the pseudocyst. However, these lesions contain a much denser fluid which can be measured. However, on some occasions they can look exactly the same. And if we try to drain them, a pseudocyst can be drained easily. However, a wall of necrosis cannot be drained easily because the fluid within it is so thick that it usually doesn't want to come out. So in those situations, then surgery is performed and the diagnosis is made later on that the lesion that we saw before and thought to be a pseudocyst turned out to be a wall of necrosis in reality. Amongst other complications, we might see an abscess formation within a necrotic area that will be suggested by areas of air within the necrotic segment. And let's not forget that the abscess can virtually go anywhere in the abdominal cavity. Here's a case from the Southwest Journal of Pulmonary and Critical Care, in which the patient with acute pancreatitis and a lot of abdominal fluid had an abscess that extended all the way down into the pelvic area. And then patients can develop fistulas, obstruction, fibrosis in the gastrointestinal tract, biliary obstruction, and various vascular complications. Sorry, this slide should not be here because I added this onto the previous one, so I will delete this later on. Chronic pancreatitis is problematic because it tends to get inflamed on a regular occasion, and the exocrine and endocrine function will gradually diminish. At CT, we will see these coarse calcifications that gradually replace the parenchyma. So on some occasions, we do not see the pancreas parenchyma at all. We just see these coarse calcifications. And since we know where the pancreas should be, then we suggest that that's probably due to chronic pancreatitis. We might see uneven dilatation of the duct, atrophy, and it can be focal or diffuse. If we suspect a pancreatic cancer, then sometimes ultrasound is performed, but usually ultrasound is not diagnostic. So in the diagnostic algorithm, helical CT comes first. If we see a mass lesion that is probably pancreatic cancer, then we need to decide whether it's resectable or unresectable. Because if it's not resectable, then patients will not be offered surgery at all. If it's resectable, then they will be operated on. And the way to decide is to check whether it extends beyond the margins of the pancreas, whether it involves adjacent organs, whether there are enlarged lymph nodes that are greater than 15 millimeter, whether it encases or obstructs surrounding arteries and veins. And that's very important, and sometimes it is very difficult to assess. And naturally, if there are liver metastases or other metastases, then those patients will not go on to surgery. If our findings are equivocal, or we don't see a mass lesion but the clinical suspicion is high, then we can move on to MRCP, endoscopic ultrasonography, or ERCP. And here is the big killer, ductal adenocarcinoma, which we usually see on ultrasound as a hypoechoic mass with faint margins, and at the same time we will see the so-called double duct sign, which means that the common bile duct and the pancreatic duct are enlarged at the same time. It usually resides in the head of the pancreas. If it's recognized early, then it doesn't have a chance to grow too big, but the body and the tail lesions are found later, so they become quite big. It's usually a disease of the elderly. It affects males more commonly, and the survival rate is quite low. Here is how we would see it at CT. So there is a faint mass in the head of the pancreas, and you can see that the common bile duct and the pancreatic duct are both dilated, and carcinomas of the pancreas tend to be hypovascular. So as you can see here on the arterial phase, the head of the pancreas and the tail of the pancreas enhanced nicely, but this lesion in the center of the image, shown by this arrowhead, is inhomogeneously hypodense, and that's suggestive of a cancer. And the power of CT is that we can not only visualize the pancreas, but we can visualize hepatic metastases or peritoneal deposits, which will make surgery unnecessary. There are other type of tumors in the pancreas, but they are quite rare. The islet cell tumors, which can or won't have any endocrine function, and depending on the type of tumor that we encounter, the malignant potential differs. Glucagonomas are the worst ones in that sense, and in the textbook it says that up to 80% of non-functioning tumors are malignant. And since they are hypervascularized, then at CT you will usually see that there is a round, white, bright lesion on the arterial phase, and that's diagnostic for an islet cell tumor of the pancreas. And last but not least, let's talk a couple words on the spleen. The spleen is never imaged on its own. It's usually part of abdominal ultrasound or abdominal CT. It has a funny contrast enhancement on the arterial phase CT. It's quite inhomogeneous, so we seldom look at the spleen on the arterial phase. We usually look at it on the other series. On the portal phase, it should be homogeneous. It should measure about 4 by 11 centimeters, but you don't need to know that. And amongst the most common lesions are rupture that we can see. So these yellow arrows on the bottom left image are highlighting an area which is inhomogeneous, and it's more hypoechoic than normal color. And in the right clinical setting, this is suggestive of rupture. And splenosis is quite common when some parts of the spleen forgot to fuse when the patient grew up, and we see them as different entities in the vicinity of the spleen. So this was my talk, and if you have any questions, I will answer them now. And as all of my talks, you can revisit them and watch them again on YouTube. I thank you for your attention, and if you liked my video, please like it and subscribe to my channel, where I try to post new videos and other educational materials every week for you.